Good morning, good afternoon, good evening, everybody. My name's Tan. I'm here today to talk about the HEAR score assessment implementation in the management of the chest pain at non-emergency medical setting. Objective: Introduction: Identify the practice area, engage change agents, assess readiness for change, review the evidence-based audit criteria, implementation change using CRIT, reassess the change, consider sustainability. Introduction: Chest pain is a common reason for the seeking medical care, accounting for approximately 6 million emergency department visits annually. The heart assess is widely used as non-traumatic chest pain risk stratification tool in the ED. It evaluates five factors: history, EKG, age, risk factor, and troponin. It's scored from 0 to 2. The total score categorizes patients into risk level for major adverse cardiac vascular events. 0 to 3 is low, 4 to 6 is moderate, and 7 or higher is high. Higher scores are associated with increased risk of cardiac death, acute MI, and coronary revascularization. Identify the current practice area. At the non-emergency clinics, as primary care and urgent care clinics, in-house troponin is not available. Despite limitation, a clinic encounters several patients with chest pain. At present, no standardized protocol exists for the evaluation and the discharge of the patient. The current workflow consists of the following steps. Patient present with the chest pain at the front desk, and the front desk staff immediately notify the back office medical assistant, and the MA quickly escort patient to the exam room and records the vital sign. Then the MA communicate the patient condition and the vital sign to the provider, and the provider determine the subsequent course of care. Thus, the objective of this implementation is integrate the HEAR assessment as clinical tool for stratifying the risk, preventing MI and MACE in adults presenting with non-traumatic chest pain with non-emergency medical setting. A cause effect diagram. Look at the first factor in the diagram is the pupil. Many people present to clinic with a chest pain, chip complaint. The healthcare provider used different guidelines to evaluate chest pain patient. Policy. There is no established guideline to evaluate patient with chest pain in non-emergency medical setting. Resource. The clinic can only perform patient history to EKG, document age, risk factor. Clinic cannot perform troponin tests and have the result right away. The last factor, the chest pain assessment. Many assessment tools are available for evaluate chest pain, such as MapBird, Gensler, InterChest, Heart, and HEAR score. As the result, HEAR assessment is not used in non-emergency medical setting. Identify the new practice area. With the new implementation, the HEAR assessment will be performed by the MA immediately after receive notification from the front desk. The provider will then review all the components of heart assessment, history, EKG, age, risk factor, and based on his score. If the score is 2 or less, the provider may safely discharge a patient. If the score is greater than 2, the provider should refer patient into the ED. If the patient declines the transfer to ED, the provider may issue the stat troponin lab order and instruct patient to do the test immediately. Since the troponin test is not available in-house, when the troponin result become available, the provider will contact the patient with the further instruction. Agent Engage change agents. This implementation involves several key stakeholders. First, the clinic owner and the management team must support this project. Once the protocol is established, on the front staff and back office MA and the provider will need to be introduced to the new workflow and receive the appropriate training. Ultimately, the patient and their health outcome are the most important stakeholder. Engage change agent to ensure the established successful implementation. The list MA should be actively involved as they serve as the first point of contact for the patient and conduct initial triage process. When the patient presents with a chest pain, the MA initiate here assessment and the MA then notify provider who evaluate the case and do calculation for the HEAR score and they decide the treatment plan. This implementation project does not require the formal project manager as it's limited to the single clinic. However, the role of the medical director and the office manager are essential for the effective execution for this project. The medical director as the key stakeholder is responsible for making the critical decision, ensure adherence to the institutional policy, and maintaining communication with executive director to support the program's successful launch. With their clinical expertise, the medical director is well positioned to evaluate and approve HEAR assessment protocol and advocate for their adoption among their provider. In addition, the office manager played a crucial role in operationalization, the implementation that given both front desk and back office staff rotate shift. The office manager is responsible for the communication, the new process, ensure all staff are aware of the implementation, and verify they are adequately trained, perform, and their respective role within the update workflow. Assesses readiness for change. The commitment to the quality improvement, the urgent care clinic or the primary care consistently try to enhance the quality care by placing patient at the center of its mission. The goal is to deliver exceptional healthcare to the patient and the community it serves. In alignment with this mission, the clinics is committed and providing the health quality care based on the most current evidence and clinical guidelines to achieve this. Ongoing effort and direct toward optimized workflow and improving patient satisfaction. The SWOT strengthening weakness opportunity threat analysis is a valuable tool for evaluating the feasibility of practice and policy change, and SWOT analyzing demonstrate the commitment to change. SWOT analysis strength is three primary strengths contribute to the successful implementation of HEAR assessment: organizational structure, workplace culture, and communication. Structure. The clinics from the strong organizational framework composed of medical director, office manager, provider, and support staff. Once the implementation is approved, the protocol is rapidly disseminated and operationalized. The medical director communicates updates to provider, while the office manager ensures that both front desk and back office personnel understand and adhere to a revised procedures. Workplace culture. Guided by its mission, the clinics is committed to delivering care in accordance with the evidence-based guidelines. The HEAR assessment support this commitment by enabling provider to safely discharge the chest pain patient with the low score 0 to 1. This not only reassures the provider of the patient safely, but also mitigate potential malpractice risk. Communication. The leader maintained effective communication through both email and in-person meeting. Protocol update first distributed electrically by the medical director and office manager, followed by the team meeting with the office manager, reinforce the protocol and demonstrate its application during chest pain presentation. Weakness. A notable weakness is the limited number of the chest pain cases available for the practice. Although clinic managers manage high potential volume overall, relatively few patients present with chest pain. While staff may understand the protocol conceptually, effectively implementation requires the practice experience. Limited opportunity to practice may result in staff not fully retain or consistently apply on procedure step opportunities. The implementation of the here protocol prevents an opportunity of cultivate the leadership within the clinic. Designated leaders sit at the front and back medical assistant lead and provide the lead can take the ownership of the protocol oversight. By first testing the leadership role, the clinic can train in accountability, ensure the consistent application of the protocol, and increase the likelihood of long-term project successful. Threat. One of the most significant threats to the quality improvement initiative is the workforce instability. Staff shortage can substantially impact the patient wait time and workforce inefficiency. For instance, insufficiency front desk staff may prolong check-in, while shortage in the back office staff can delay triage and order completion. Most critical risk is the exception of the provider, which would result in clinic closure and financial loss. Consequently, the workforce shortage presents a serious barrier to the successful execution of the quality improvement project. Review the evidence-based audit criteria sampling. The population of the patient presenting with the chest pain vary by age, ethnicity, and socio-economic status. The quality improvement project focused on the adult patient aged 18 years old and older, without distinction by ethnicity or socioeconomic backgrounds. Because of the number of demographic of chest pain patients vary from day to day, the sample population will be included on adult patients presenting with a chest pain complaint. The data collection period will span approximately 1 month to ensure an adequate number of the patients for evaluating the effectiveness of the quality improvement initiative. The sample size will be determined by the naturally occurring flow of chest pain patients at the daily volume of the such case is unpredictable. The method. Few studies have utilized observational study design to evaluate patient presenting with the chest pain. This project, the patient sample will collect through the EMR system. The data extracted from the patient records will include the demographic, past medical history, EKG, age, and the cardiovascular risk. The HEAR score calculates is performed. The Table 1 provides an example of data collection framework. Using the current medical records in the clinic, the audit will be determine how many patients receive the completed HEAR assessment compared to those who did not undergo the assessment. Implementation change using CRIP. An overview of the steps for getting the research into practice is used to develop effective implementation strategy. Have three major factors of CRIP are: evaluate baseline of audit finding, identify the barrier and able evidence utilization, determine and implement strategy for change. Evaluate baseline audit findings. Several assessment tools include McBurd, GANS, and the InterChest score are available for evaluation chest pain. However, the instruments are not optimized suited for the urgent care setting, as they primarily emphasize the diagnosis coronary artery disease 10 acute coronary syndrome. Consequently, they do not directly address the urgent clinical priority to determine whether a patient in the urgent care setting is experiencing an acute cardiac event. In the emergency department, the HARS and EDAX assessment are commonly utilized. The tool is effective at identifying acute coronary syndrome and support the provider to safely discharge patients while minimizing the risk of overlooking critical conditions. However, both require troponin tests, which not readily available in urgent care setting. The here without troponin assessment presenting more appropriate tool for the urgent care practice. In contrast to the HART score, the HEARS does not rely on troponin testing and instead focus on evaluating the likelihood of chest pain associated with acute coronary syndrome. Moreover, the provider is valuable predictive information regarding the risk of major cardiac events, thereby offering a practical, effective approach in the urgent care setting. Identify the barrier enabler to evidence utilization. The HEAR assessment tool presenting several limitations. First, they remain relatively unfamiliar to many providers as the result is not widely adopted for evaluation of the chest pain. It's limited to use the stem from primary design which escalate the acute coronary syndrome rather than established definition diagnosis. For instance, the patient with a HEAR score 0 to 1 can typically discharge safely. However, the score above 1 provides insufficiently guidance regarding severity of the chest pain or appropriate the next step in the management. Additionally, many validation studies of the HEAR score have been conducted within narrowly defined patient population and demographics. This restriction the generalizability of the tool to broader population that were not presenting in the validation process. Determine the implement a strategy for change. The objective this quality improvement project is implement HEAR assessment to arm patients resent to clinic with the chest pain as their chief complaint the end 2026 as documented in the EMR system. To achieve this objective, address potential barrier comprehensive training education on the HEAR assessment will rely on the healthcare provider, medical assistant, and the front and back office staff. Understand the new workflows when the patient presents with the chest pain. The front desk staff will immediately notify the back office MA. The MA will then escort the patient, obtain the vital sign, document relevant information, and lose medical history, age, risk factor in the EMR. Follow this, the MA will notify the healthcare provider upon provider authorization perform EKG. The provider will subsequently review uncollected data, complete the HEAR assessment based on the patient HEAR score. The provider determine the appropriate clinical management and the plan of care. Reassess the chance and consider sustainability with implementation of HART assessment on component of the EKG-ACE risk factor should be documented in the EMR along with the calculated total HEAR score. This documentation enables healthcare providers determine the most appropriate treatment plan for each patient. Accordingly to the EMR records should be reviewed and analyzed, audited on the regular basis. Auditing to ensure the accuracy, completeness of the records, while also identify instances of missing data. While when information is absent, auditor must determine the source of the error. For example, if the patient history is missing, it may be due to an oversight by medical assistant or because the patient was too ill to provide the detail. Similarly, if the HEAR score is absent, the provider may have calculated the HEAR score but neglect to document it. In some cases, urgency of the acute chest pain management may lead the provider to prioritize treatment over documentation, thereby create a gap in the records. By systematically collecting the data, encouraging staff experience, audits can assess both effectiveness and efficiency of HEAR assessment process over time. To ensure sustainability, supportive management structure is essential. EMR chart for the patient presenting with the chest pain serve as the primary document for audit. The EMR system should be designed to facilitate effective document on the HEAR assessment component both medical assistant and provider. Designated facilitator will oversee the process, monitor the process, identify challenges encountered by the team member during implementation. Equally important is development proposed transparent feedback mechanism. Members must be given structured opportunity to share the concern to provide feedback regarding HEAR workflow communication. Channel will include email correspondence or semi-weekly meeting, during which issues can be discussed. Patient complaints when received will be addressed to this avenue. Finally, fostering shared sense of system improvement is critical. All the feedback will be reviewed collaboratively by the medical director, office management, and facilitator. In the event of reassure or insignificant error are identified, the new Plan Do Study Act cycle will be initiated through the process. The quality improvement team will work collectively to develop implementation effort solution. Conclusion. The primary goal of this implementation is establish HEAR assessment as standardized clinical tool for risk stratification, enable healthcare providers to prevent acute MI and major cardiac event in adults presenting with non-traumatic chest pain in non-emergency medical setting like primary care or urgent care setting. The update guideline on the HEAR assessment. HEAR assessment provides the clear framework for evaluating patients with chest pain and outline workflow for all staff. Remember, as a result, the patient can receive the timely, appropriate care through an efficient and well-coordinated process. With this implementation, the patient with the chest pain, who are the central stakeholder, benefit from consider the level of care and treatment, leading to improved satisfaction. At the same time, the provider adds support to minimize the error to ensure the greater accuracy to the clinical decision-making process. Thank you so much for listening to my presentation. If you have any questions, do not hesitate to email me at my email. Thank you.